very warm welcome to this first of our roundtable discussions, our social care roundtable discussions. And this one is on the structure of social care. So I'm Sue Jones, Director of Social Care. And what I'm going to do is actually ask our very lovely panelists to introduce themselves first of all. And then we've only got 4 questions that we're going to ask. But obviously these 4 questions, we are going to put those in the chat. The purpose of this sessions and the other sessions is really to get as much feedback from our members as possible, because what we are then going to do after getting all of this information is to compile it, and so we can actually present that evidence as well. So that's a really important part of what we're doing. So I'm going to go around the panel, if that's okay, and just get you to introduce yourselves. So Eddie, I'm going to come to you first.
Okay, thank you, Sue. I'm Eddie McDowell. I'm Chief Executive at Oxfordshire Association of Care Providers. We also support our neighbours in Buckinghamshire Care Providers Association. I'm a Director of SESCA, which is the South East grouping of care associations, and I'm also co-chair of the Care Association Alliance, which is the national family.
Thank you, Eddie. Thank you very much for coming along today. Palvi, you next.
Hi, I'm Palvi Dodia. Along with my husband Jay, we own Serene Care, which is a number of care homes in the Midlands.
Thank you, Palvi. Jasmeet.
Hi everyone, I'm Jasmeet Rai. I'm currently a social care consultant specialising in supporting care providers on their journey to net zero. But before that, I was Associate Director of RCH Care Homes for 5-6 years, where we are based down in the southeast and east of England, and we predominantly specialise in residents who are living with dementia. And Palvi and I were co-chairs of the People Plan, like way back when, last year, 2 years ago.
And
very happy to be here.
Fabulous that was too. Jyoti, would you like to go next? Oh, sorry, you're on mute. Sorry.
Yeah. Hi, I'm Jyoti Vitlani. I'm a retired university lecturer, but very active still with Leadership Academy in my community here. So I've been a patient rep in the Royal Colleges, etc., as well. So bits and pieces still going on, and an active member, I think, as a retired person with IHSCM.
Thank you, and I know you do contribute to our social care innovators as well, so thank you for that. Trudy.
Well, hi there. So I'm the CEO and founder of a home care organisation called Bellevue, so representing home care organisations here. And we operate in Oxfordshire, Buckinghamshire, Northumberland, and a little bit of Newcastle. And our difference is that we have brought a bit of the Dutch model, the Buurtzorg model of self-managing teams, and we've incorporated that within our model, which we've been using now for just shy of 6 years.
Fabulous. Thank you so much. So I wanted to start with something quite big. So this is a really big question, but the reason why I'm asking it is because it just seems that everything has become so complex in social care. You know, there are so many different component parts to social care. So for me, it's almost like stripping all of that back. So the question I would like to ask our panel members, and we're going to put this in the chat as well, is what do you think good social care should look like? So who would like to go first with that question? Big question. Alvi.
Hi. I think in the recent times things have become a little bit difficult, where everyone's forgotten why we all got into social care. There's a lot of politics versus NHS and social care, but as a care provider, I've done this for 12 years and it's never been as hard as it is today. We've got discrepancies between what the regulator expects from providers. We've got a lot of differences happening because of the government. We've got lots and lots of issues in terms of fair cost of funding, what our actual funding rates are going to be. But we've forgotten why we all came in, and that was to actually help the outcome of people. And that's what I think is really sad, because we're all sitting there worrying about what our ratings are and what our occupancy is and all of that. But why did we get in there? It was help people have the best outcomes in life. And that's where we need to work together to get there. And if it is NHS and social care integrating, then so be it. If it is not, that's fine. But we just need to get to that solution. And I think that's the problem. We've forgotten the reason. And it's taking the care out of social care, because we're just sitting there doing a lot of admin, arguing about points, and then the governments come in and just change it, and then the regulators say something, and then someone else says something, and it's very difficult. I've never known it to be as difficult as it is right now.
Thank you so much for that, Palvi. Really appreciate those thoughts. Trudy.
Yes, I certainly agree and would build on the outcomes point, Palvi. And so, I think what we need to do as a group within social care is look forward and say, okay, so things have been difficult, but let's get some of the good ideas from within our communities and working with others, and find innovation. And so, Palvi mentioned outcomes, so I'll perhaps start with that. It's like, well, where else? Where can we learn from that doing outcomes well? And you don't need to go that far to nip over to the border into Wales, because there's some quite innovative stuff there around incorporating outcomes in how they do commissioning. And there's still, there's still a lot of work to be done in Wales, but they're ahead of us. And I was pleased to hear the Welsh Commissioner talk in the autumn and saying that she'd welcomed some of the English government over to conversations. I'm not sure if that's taken effect over here yet. I haven't seen the results of any conversations, but wouldn't that be great if we could drive some more and learn from other countries like Wales? I think innovation around funding has got to happen. So perhaps look at other countries where insurance models have taken off, and what can we learn from there? We've got an aging population, so finding the money to support everybody is going to be tricky. And I think successive governments have kicked that can down the road. So what are our learnings from that? And I'd love to see people more qualified than me look into that and present stuff back. Looking at different models, which I can talk a bit more about. So we looked at the Netherlands and saw Buurtzorg and went, this is a different model. And back to Palvi's point, it's about people and outcomes. And so we're using that. That's not the only model, though. There are other models. But time and task, I don't believe works. And so why are we still doing it? And there are reasons. So let's move away from it, though, because we can. And then the last one is looking at technology as an area for innovation. And technology not to replace care workers, but to enable care workers to spend more time caring, and to enable things like forecasting supply and demand, etc. It's not all about robots and the fancy stuff. It's just doing our work better. And I think if we were to work solidly on those sorts of areas, we could really make change happen.
Fabulous. Thank you. Thank you so much, Trudy, for that. Oh, Jasmeet, first of all.
Okay, sure. Yeah, completely agree with what Palvi and Trudy have said. I think good care at its core is essentially supporting people to live the lives that they want to live. So supporting them to be as independent as possible, to be as fulfilled as possible, to be as happy as possible, like at its core. And so whether that falls into things like, for example, if someone's from the LGBTQ plus community, making sure that they don't go back into the closet once they start receiving care, whether it's home care or in a care home, etc., or whether that is providing more trauma-informed care to everyone, because the stats are 1 in 6 women in the UK will face domestic abuse at some point in their life, and 1 in 4 men will experience domestic abuse. So those things, and especially when you are looking at aspects, for example, dementia care, where people might not always remember what's happened, but they remember the feelings and the sensations that they associate with the certain things. I think we need to have trauma-informed care collectively, and I think we need to improve. Well, we need to have a real focus on the mental health of everyone, both the workforce and the people who are receiving care, because if you focus on all of those things, and if we collaborate as a sector, because there's so many great innovative things happening already in the sector, we just need to find a way to band together and work, whether that's working upstream and downstream of each other. So instead of being in competition with the care home or the home care service down the road, is there a way that we can work together so that, going back to the people who are actually receiving the care, they receive the best care possible? And also we need to think about the climate as well, but I will come to that later.
Thank you, Charles. You make some really good points there. Thank you. Eddie.
So being the oldest person on the panel, Sue, I think I was going to take a historical perspective. And when you look back at the way care was delivered in the past, clearly it was hospital-based, building-based, etc. Most care, whatever that might be, took place within a setting that was mainly health controlled. And we've moved a long way now, where a lot of care that we provide is taking place in the community, in people's homes, out and about in ordinary places, which kind of echoes what Jasmine just said in terms of care being very much out there. So I think we need to decide, do we want to continue that model, if that's the right model? And I think we're probably in agreement that it's better to have something which is integrated and out there than hidden away. We need it to be integrated with health. So one of the problems I think we have in the UK is that we have probably the last remaining crown jewel. So after Queen Elizabeth II died, probably the last remaining crown jewel is the NHS. I'd imagine that binds society together in some way. And therefore we've got this kind of monolithic health service which can spend seemingly as much as it wants and never go over budget. And then we've got a care system which is constantly scrapping for pennies under the table, and the two things don't really fit very well together. But I think we also need to integrate our care with society. So I think we often talk about integration with health, but actually, how well do we make sure that the work that we do out in the community is connected to what people do? So I'm talking about employment opportunities for people who have a disability. I'm talking about making sure that we are making the most of our community connections for people, making sure that they are not passive recipients of care, but actually active are participants in what they do in their lives. So that would be really important. And then when I think about that, actually, I think we also need to think about then the wider things that sit around care. So benefits, the benefit system. And we need to make sure that that begins to work for people who receive care. And I'm guessing people also who support care, like unpaid carers. So there's a lot of these facets. And when we look at social care, we tend to look at it in isolation, but I think we need to look at it in those with those different connections. And then my last comment, which kind of nods to the kind of the second thing that we're going to be looking at, is just actually, in a way, the mechanics of delivery are not as important as adequate funding. But we'll kind of come on to that. I'm sure we'll touch on that today, but we're going to explore that in more detail in a later webinar. But I think, in a way, we're talking about this now in endlessly trying to find a solution. And that's partly because we don't have adequate funding in the system.
Mm-hmm. And I would agree. I know I was listening to one of the local authorities, and they were talking about how they've commissioned care and they got away with time and task care, and they're looking at, being more almost well-being led. However, the funding is still the same. So you can't change things without fundamentally changing how much it's actually going to cost either. You can't have both. You can't do this with minimal amount of funding, can you? You've got to look at the whole thing. And you were just saying that, you were talking then, Eddie, about, how the other people, that you need to get communities involved, and that's all parts of communities, isn't it? So that's education, that's housing, it's everything, isn't it? It's in the benefit system. So absolutely. Sorry, Jazz, did you want to add on something there?
Yeah, just in terms of what you're saying about the funding, completely agree. Until we have adequate funding, it's really hard to change anything. But what I will say is that in order to have adequate funding, I think we need to have, as a society, a really honest conversation about what care work is and what it entails. And there needs to be a cultural shift. Like at the moment, the majority of unpaid care work falls on women, whether that is daughters, mothers, partners, granddaughters, whoever that is the majority of it. Trusted Care push out a report, a marketing and demographics report every year, and one of the things that the metrics that they measure is who is the person who is calling up to ask about like the provision of care. Often it is the women in that person's life. We need to have conversations about benefits and how, as Eddie was saying, the benefit system, where at the moment we culturally as a society, or like this is mostly being pushed by the media and partially by the government, is we are demonizing people who are on benefits. But the number of people who are on benefits and who are economically inactive are often people who are disabled and can't work. They want to work, but they can't. Cutting their benefits is going to make their ability to just survive that much harder. And when we talk about things like benefit fraud versus tax evasion is so much higher than what benefit fraud is. Benefit fraud is minuscule in comparison, but as a society, we're not having those conversations. We're not having conversations about, as Eddie said, like housing, or sorry, Sue yourself said, housing, schooling, education. Like if whatever we do, there needs to be a real cultural shift, and where a lot of people, they don't understand how much the cost of care is. Like the average cost of care a few years ago was £1,100 a week for basic residential care. I appreciate that is not the same across the entire country. It's an average for the entire country, but that's basic care. Once you then factor in more complex care needs, etc., a lot of people don't, outside of those who are actively already receiving care, they don't know how much it costs to provide care. So we need to have an honest conversation about that as a society.
Yeah, absolutely. And how and where are our responsibilities and accountabilities for that? You know, we're what are we going to do about it as well? Jayati, did you want to come in there?
There are two things. One is like people are not keen to go to care homes or receive care. And it's partly because I see people around me. These are all people who have been very well in their own time. And when it comes to them needing care, they're reluctant, which means the carers are ending up doing lots. Again, I see that a lot with people around me, so I totally agree with what Jasprit was just saying as well. So the reluctance for people to accept is partly because of the way people get treated. It's more about, oh, I'm a burden to people, that sort of a thing. And I was also listening to you and yours last week, and oh my God, the stories that people were telling about one man was talking about his wife getting dementia, and I thought, how sad. We shouldn't be putting people into that sort of a sad position where he was feeling, I've got funding for 1.5 years. I don't know what will happen to my wife afterwards. As it is, people are stressed when someone goes into care, and then, this makes it worse. So we need to look at something around how we can make funding of care better, and also for relatives to not feel so burdened about it.
And it's that security, isn't it? It's knowing that it's once it's there. So it's a benefit that will see you through, rather than just a temporary, short-term thing that is provided to you. Absolutely. Eddie, did you want to come in there?
Yeah, I just wanted to pick up on that comment actually around families who look after family members. So it's always stuck with me, actually. My background originally was learning disability services, and it's always stuck with me how many older parents looking after their adult child. And trying to get inside their head a little bit around what they were thinking as they struggle on a day-to-day basis until they're very, very elderly. You know, often it's not unusual to see a sort of symbiotic relationship between an elderly parent who may be physically frail, maybe failing sight and hearing, and a physically active older working age adult who may not have their complete cognitive ability, but is physically able to do things like the housework, etc., at the sort of direction of a parent, and how that works, and how that parent must feel when, as they get to the point where they can no longer look after themselves, let alone another person, what will happen to their child effectively, as when they die. And I think that's probably the nightmare of all of us, if we are parents, that we wonder what would happen to our children. So I often think about that particular relationship. We, as a society, we've moved away from families generally, in most parts of the country, families looking after relatives, because we have such a mobile society, people moving about the country, growing up in one area, moving to London or another big city to work, and that often means we live many miles away from and many hours away from our relatives. And that causes societal fractures, of course, in terms of when that person then requires care, who's going to be around to look after them, you know, oversee it on a daily basis, etc. And then we become totally reliant on, with respect, you know, anonymous care companies who we have to get to know and have to understand how they work and begin to trust. And I think that, you know, there's a fundamental problem, I think, therefore, in our society in terms of how we support care companies, because care companies can't do it all. They can do some of it, but they can't do all of it. It has to be augmented by families in some way.
Yeah, absolutely, 100% agree on that. And I know that we've almost started to cover the structure as well. Trudy, did you want to add something in there?
Oh, just to build on Eddie's point, that perhaps then, because I agree, it's something about community there, and maybe the role of the care companies is it isn't about taking charge, but it's more of an enabler. And how do we take our responsibility as a care provider to build communities and enable connections, and that feels like a different role, more about us being there to serve others and to serve the communities, which would benefit society, and is why we're all in it in the first place.
And, you know, absolutely. And I know we are moving towards that structure now, because it's almost, I mean, I know Scotland has scrapped the National Care Service. They've scrapped, they did quite a lot of work on that. I know Wales, I think, so you might know better than me, Trudy. I know I live in Wales, but I don't actually get to operate within social care within there. But I know that they're still looking at a National Care Service within Wales. You know, certainly from what I'm hearing is that even though we seem to have, and we're supposed to have, an integrated care system across the England, but I'm not sure how well that's working. So if it's not working, as being diplomatic, if it's not working, what other structures do we need? You know, what other things? And I think you've just absolutely beautifully articulated that within the panel, is having that community at the foundations of that. You know, this is about individuals and communities, and how do we actually support people? What would that structure look like? And again, opening that up to the panel in terms of the structure. What are your thoughts? Eddie? Oh, sorry, is that from previous, Trudy? No, Eddie.
Okay, so I think, Sue, if I'm right, John, I'm sure John will correct me, you'll correct me. There are 4 models, aren't they, of funding? I don't want to go into detail because I say we're covering that next time, but so we've got the beverage model, haven't we, where effectively it's, you know, national service, which is free at the point of delivery. Then we've got a Bismarck service, which is effectively you kind of pay something towards it, and then there's the national health insurance where you all pay something in and then you get something out, and then there's a kind of American system, or part American system, where you pay it out of your pocket. And I think when, for many of us who've travelled across the world and we've had to use care systems elsewhere, healthcare systems probably, when we've gone to other countries, you realise actually that although we have a huge number of problems with the UK system, it's a hell of a safety net, frankly. You know, having been to the States and had to kind of worried about how my son was going to be treated for a short-term illness that he had when he was there. And the relationship that you have when you're paying someone, so you have your treatment and then you go through a cash till at the end to pay for your treatment, changes the relationship that you have with the clinician, effectively. So are they doing something to get the money, or are they doing something because they genuinely want to cure or, you know, treat the patient? And I think I'm sure they're all very trustworthy, but it does make you question what it should look like. So I think I mentioned earlier around this monolithic NHS and then our fragmented social care. And one of my thoughts is whether it's simply possible for those 2 elements to continue to exist alongside each other. And I guess that's where government is going. And there are 2 possibilities, I suppose. You create a national care service, or you fragment the NHS even further than it is already. So I kind of stop there and see what people think about that. But it feels like it can't go on the way it is, because we've got 2 different sized things.
Yeah. yes, you've got the NHS there, haven't you? That basically that is fully funded, isn't it? But you've got a social care system that is just, it's not fully funded. Jazz, did you want to come in there?
So I'm partially going to answer this question, and then there were some other points I was going to make. I think I completely agree that you can't have both systems running simultaneously next to each other. Like, it's just not feasible in the long term. It might work for the next 5-10 years, but over the next 20, 30, 50 years, it's not going to work. I am a firm believer in that universal healthcare is a right that everyone should have access to. But if you are going to try and create a national care service within the UK, then that again requires a lot of really honest conversations that no one is currently willing to have about things like taxation. At the moment, everyone wants to lower their taxes and receive lots of services. Those two things don't work. Someone needs to pay high taxes, and you've got energy companies like 2 years ago who were saying, put a windfall tax on us. We've got so much money that we're making right now. Even if you put a tax on us, we'll be fine. It's not really going to impact us. I also really need, sorry, this might be something to say for the next session where we're talking about funding, but the difference between a millionaire and a billionaire, and just to put this into context, if you had 1 million seconds like lined up next to each other, that would take up 11 days. If you had 1 billion seconds lined up next to each other, that is 31 years. So when people are saying tax billionaires versus tax millionaires, there's like a huge discrepancy and in what is possible. And like, I think billionaires, most people just don't really understand how much money they make and how much they could help more. But again, that's a separate topic. The points that I was going to make about the community aspect is that who are we calling community? Because at the moment, what it feels like, and everyone can feel free to disagree, is that we're saying community is basically the people who are receiving care. They are able to stay in their homes, and that's not community. Like, that is where they are living, but community is all of the people around you. And just taking it out of social care for a second, at the moment there is a huge unequal balance in who performs a lot of that emotional labor, that invisible labor, that community building. So if you think about a recent time where someone who someone has passed away, like a friend's parent has passed away, or someone's had a newborn baby, or someone's had like an injury, an operation, and who are all the people that are organizing the meals to make sure that they're able to get through for the first few weeks while they're grieving or supporting a newborn, or so like, healing from their injury / operation. If in your personal life, the majority of those people are the women in your life / in the other people's lives, then that at the moment, if you're saying community-based care and we're just expecting women to carry on doing a lot of that, it's not going to be feasible. Like, when I talk about cultural shifts, we need to, I know this is not all men, there are a lot of men who do step up and who are equal partners, etc. But if we're talking like on a societal level, and maybe this is different within social care versus outside of social care, but definitely outside of social care, if you have such an unequal balance, then like you can't talk about things like community building and community care unless you're talking about the cultural shift that's needed to talk about the imbalance that currently exists of who provides care work.
Yeah, very good point there. Yeah, lovely. Thank you, Parvi.
So I want to talk about, as a care provider, how difficult it is actually discharging residents from NHS to social care, because I think that's a really important point that we need to bring together. Because what's happening now is, because there's a funding gap that we're talking about, people are being sent home. So as Jazz's point was that, people are going home, but what happens is they're then going home to fall and fail. And when they finally make it into a care home, they're so much worse than they would have been had we had the correct funding structure. So we're in this vicious cycle now where people are coming into social care a lot worse and a lot more prolonged down than what used to be there before. And that's because there's that separation between local authority funding and NHS funding. So everyone's got their own pot that they're fighting for. So any local authority have to try at home, even if they know it's going to fail. The other flip side is when we say as a care home provider, oh, actually, this resident's needs are really high, we need a bit more extra funding, they'll then weaponize that against us and turn around and say, well, you can't meet their needs, we'll just send them to another care home, which isn't the best outcome for that resident, because we just need a little bit more extra funding because they might need a few extra hours within the care home. So again, I think that is the massive issue, And when we highlight these things as care providers, governments do reports that take another 3 years. So we'll find out in 2028 what they're going to do about fixing something, which, again, we're talking about. Jazz and I really enjoyed writing that report the first time. It's the same report that's going to be published in 3 years. How many more reports do we need to talk about?
Exactly.
As social care and health just need to work together. And ultimately, it is the fact that they're not talking to each other, that these residents are being well, I don't want to say bed blocked, I know that's not the phrase you went to it, but there's so many people that should be discharging out to the right place, but they're not being discharged.
And I think that goes to absolutely the fundamental point, is that why do we need to change? And I know I was just speaking before we actually came on the live session, is around having different models. You know, I know, Trudy, you do a lot on Birtsorg and how that actually helps. But it does save money, and there's lots of evidence that if you use a human systems approach, that it can actually save money. I know it's certainly something I've experienced as a family, is that if you use the right approach, it can save money. Sorry, Eddie, did you want to come, and then I'll come to you, Trudy?
Yeah, I'll just be brief because I've spoken recently. You know, Palvi's absolutely right in terms of that funding. It's ridiculous. It is absolutely driven to get people out of hospital, and the rigidity in terms of those funding streams. So if somebody has a long-term condition, or they are an elderly or vulnerable person, it's highly likely that their needs will change week to week. So they might need a bit more input this week or today, and not so much next week. The funding streams changes, it stays the same. So, you know, it should be a flexible pot which allows the care provider or the individual to access things that they need, whatever that might be, care or activity, when they can do it, when they need it, and then shrink again when they don't need it. And at the moment that whole system doesn't work. It's all supposed to be personalised, but actually it isn't. It's all driven by effectively local authority budgets.
Yeah, absolutely, and this is the problem. And I'm trying not to talk about funding at the moment, because we'll come on to that next week. But it is undoubtedly, it does link into the structure. Trudy, did you want to come in? Because I know you were talking. I know we were specifically talking about new models of care and the benefits of working towards that.
Yeah, so I'll build on that and try and focus on the model rather than the funding, because I'm very much looking forward to your next roundtable on that. So new models of care can be beneficial from an economic point of view as well, but we have to be really careful. So if you look at Birtsorg in the Netherlands, for instance, one of their successes is that they've saved the Dutch government money. And it would be tempting for us to say, well, actually, by introducing a Birtsorg type model in the UK, which is what Belvi's doing, that we could save money. But actually, I struggle to put that as our biggest selling point, because there are some fundamental differences. In the Netherlands, they were already spending quite a lot more money than us, and we do not. The budgets are just different, and so we're not about immediate cost cutting. So if you're just looking at the immediate pound per hour, then our model does not look cheap. What you need to differentiate is you need to look at the length of time, and you also need to differentiate between the economic case and the financial case of a model. So in our model, we're doing work to measure outcomes, the impact that we're having on people's lives, and that's the people we support, it's their circles of support, and so the communities that they're in and the health professionals they work with. It's also the impact on the care workers' lives and their productivity, because there's an impact to our communities on that as well. We have a really low productivity compared to the rest of Europe in this country. It's a problem, and care work is a massive employer. We employ more people in adult social care than the NHS. And so if we look at the productivity of our workforce, that's to the benefit of all. But the economic case and the financial case are different. If you implement a new model, which delivers better outcomes for people, then it doesn't mean that you're necessarily going to suddenly find money in a budget that's there. But it does have an economic impact, because the future economy of that demographic looks better. But this is bigger picture stuff. Absolutely. It needs long-term thinking. I see that there's
absolutely.
And Exactly. There's some research just funded by the NIHR that's just started to look into this, which I think is great. However, just use your common sense now. That's what I implore politicians to do, because it's there, it makes sense. And we need outcomes-based. If you really want to say it properly, it's actually trust-based, which I think is what Eddie was talking about as well. Trust-based commission.
Absolutely. Trust-based commissioning that starts with the person first, and by listening and actually achieving what they actually can achieve and working with them, it massively impacts their whole lives rather than just a tiny little part of what, you know, they've come to the doctor with or whatever. You know, it is a whole approach. Now, I'm going to have to move on to the next question, if that's okay, because I'm very conscious that it's 2:05. So the next question, if that's okay, then we'll come, if we've got time, we'll come back to it. Now, the next question is, what would good access to social care look like? And I think this is a problem, and it is a problem because if anybody's had to navigate through to social care, which certainly we've had to do on a number of occasions, you know, it is extremely disjointed. I know that there's some really good practice, and if anybody's got that access to local area coordinators, local area networks in your area, I'd love to know if anybody has a really positive experience of that. But again, just want to ask the panel, what do you think, what would good access to social care look like? I'd like to take that one first of all. Eddie.
I'll go first. It has to be consistent. So there are lots of conditions that people have, and I'm thinking of acquired brain injury as an example, which simply don't have frameworks to provide any kind of support, and it's left to the individuals to try and seek something, because we have such a focus on older people in this country because there are obviously it's a larger cohort. But it actually dominates our social care discussions. So I'd like to see some kind of consistency across the different lifelong limiting conditions, which if we supported them well, again, people could become active participants in society instead of passive recipients. I think also just not the duplication, the fragmentation again of 152 local authority systems. You know, it's interesting how when we've talked about National Care Service, we've talked about joining up providers or joining up care delivery. What we haven't really talked about is joining up care commissioning, which is, you know, Trudy delivers services in Buckinghamshire and Oxfordshire and other places. I probably couldn't think of two different systems, more different systems than Buckinghamshire or Oxfordshire in terms of how they commission care. They're extraordinarily different in terms of, you know, what they do and how they seek new contract with providers. But I also want to say actually that in a way we aren't commissioning care anymore either. We're procuring care because again we're all driven by budgets. Commissioners have an envelope of money to spend, and therefore it doesn't give them any kind of flexibility in how they commission that care or what they're asking the provider to do. And to go back to what someone said earlier, it's absolutely driven by time and task.
Absolutely. Thanks, Eddie. Palvi, did you want to come in?
Yeah, I think one of the things I find really interesting is the fact that because I work in a care home or I have a care home, I seem to understand the social care system, but the amount of people that speak to me because their parents need social care and they just don't know what to do. It's just shocking. Where is this information? I find that really bizarre that people have to come to me, and I'm happy to help. I mean, I think you guys know me well enough to know I'll help anyone. However, why is it that they have to have a relative or a friend who's a care home provider for them to find out how to access social care? Just absorb that information, that isn't public information. It's not.
And it depends on where you go. I mean, I work in health and social care and I didn't know. So yeah, and I really had to, it's hidden. It's really hidden.
Yeah, and the amount, like just last night I was on the phone to a close friend and he was like trying to put his mum in his grandmother in a care home, and they didn't understand the funding, how it works, what top-ups are, what needs are, what assessments are, and I'm happy to sit there with all my friends and relatives and anyone who needs it. But how has it become my responsibility to teach everyone how social care works in this country? Surely someone has a responsibility somewhere to put this information in a public domain and say, this is how social care works. Even if it's not great, This is how you do it. These are the steps. If you need a care home, this is the difference between local authority. This is the difference between private. This is what a top-up is. This is what financial assessment is. This is what dom care is. This is what care homes are. This is what nursing is. I mean, I have to recycle that information to as many of my friends and loved ones, and I'm more than happy to do it. But I can't signpost them to the right place.
And
I
that's
find
really the people that you talk to, and you think of all the others that don't have access, won't know where to go.
And I remember in my personal experience, my dad was given the most shockingly bad advice about social care. And I was like, Dad, why are you listening to them? You know, I know this is rubbish. But the fact is, the public information he was given was absolutely rubbish. And it was just, my dad's got full capacity and they were telling him he needs to go to a care home. It's like, well, Dad, I'd love to say that that's how it works in this country, but it doesn't work like that. You can actually say, no, these are the things, these are the steps. But that's what I didn't understand. How is this not public information? And I think that would be something that we really need to work on, is we're trying to fix it on one side, but maybe we can just advertise how it works, at least now, because there are people that need the access to this right now, whatever this is. Even if it's not great, it needs access to it, but they just don't know under what scenarios, what circumstances, who to speak to, when to speak to them. And it's when you're at your most vulnerable, who has time to start researching then? Absolutely. You want to know these things before you actually need it. At that point, when you need it, you're already ready to go, oh, okay, if I ever need it, I need to go and speak to A, B, C, D, and not be so stressed out because you're overwhelming a family friend with these questions, which I don't ever find it overwhelming, but you know, they don't want to keep burdening me with these questions. I'm like, no, it's fine, just send this information. But I've just had that many people reach out to me recently that I don't understand, why isn't it public information?
And that is absolutely a key thing. Definitely, it needs to be centralised and signposted. As I say, I know that there are local area coordinators, local area networks that do this, but it's only available in a very, very small part of the UK. Jyoti, did you want to come in there?
Just to add a little bit on what Pallavi has said, it also works for those people who got someone to advocate for them and negotiate for them, because I've been through these sort of things with my mom. They gave everything that they would give a woman her age, but it wasn't working for her because this is so much individual and personal to people. And in the end, I had to step in and negotiate and work around it all. But you need really someone who is able to do that. Otherwise, it doesn't work for people.
Absolutely. And you make a really good point there, because if you don't have an advocate who you've got, and I really do feel for people in the UK who don't have an advocate who is able to navigate through to them. And I am conscious of time, Giles, so if you've got a quick point, then I'm going to move on to the final question.
Sure, I will be very quick. I agree with what everyone else has said, so I won't repeat that. But what I will say is one of the things that we do need to be taking into consideration when we think about good access to care is not just what good access to care looks like now, but what good access to care looks like in 5, 10, 20 years time, etc. And one of those key aspects is going to be long COVID. Like at the moment, this is such an what's the word I'm looking for? Not enough people are talking about the impacts of long COVID. It's a huge umbrella term. It covers a lot of different conditions. And there is study after study that's now coming out to show that the impacts of having had COVID, whether it's a mild case of COVID, whether it's been a more, like debilitating case of COVID, it's causing early onset of dementias, early onset of Parkinson's, early menopause. A lot of people are ending up with heart attacks, strokes, cardiovascular issues, gastrointestinal issues. Some of those ones, and a lot of people are also ending up with like long-term fatigue, and to the point where they really can't do much more. They've gone from being very active members of society to barely being able to do anything. So good access to care isn't going to just be everything that we've already discussed, but it's also going to be the fact that there's going to be a lot of working age adults who are going to need care and access to it and the information about it much sooner than they think. Like some of them may think they won't need it for another, let's say, 40 years. They might need it tomorrow.
Yeah, Absolutely. And again, this goes back to having a whole person approach, because if things are being missed, it's just getting sidelined, and anything is just not being addressed at the right time, which is making it even worse. Jyoti, did you want to come in? Did you have a quick point?
Just a quick one. The GP services are so poor, nothing to do with social care. Well, if there was better access to GPs, perhaps there would be less burden on the social care, I think, because small things could have been addressed and things it would have saved people getting worse, I feel.
Yeah, absolutely. And this goes to the whole approach, isn't it? It's not just GPs, there's district nurses, it's all social workers, it's everything, isn't it? It's that lack of that's just, unfortunately, it's not there. Okay, so the final question is for this session is, what technology could be used to create efficiencies but also improve outcomes? I know we've got two big techies, Palvi and Trudy, and of course Jazz as well. So Palvi, did you want to go first there?
Yeah, so in the care home, my partner Jay absolutely loves AI. So he will use AI and he will try and digitalize every aspect of it. And that has really, really helped us grow from 1 care home to 4 care homes, because putting in systems where you can remotely monitor everything has been a game changer. And this is where we can put better outcomes for our residents. And that's the end goal. But what it is, we all know there's so much paperwork, there's so much record keeping, and it's so important that it's done correctly. So having all the information there and for us to be able to monitor it is really good. The other thing we're really keen on is having like wearable tech, having preventable technology as well. So things, even if we use things like Alexa, tech to just help improve lifestyle. And that's been a really, really big thing that we're advocating for, because we can't keep putting in more staff in the care home. It's just not working. We can't afford it. It's also not necessary. We can actually just use technology to drive the efficiencies in saving the costs that we need to, but making sure that everything's done in a streamlined manner, which also gets rid of a lot of key man dependence on people, which I just love, because right now, whilst I'm sitting at home on this system, or right now doing the webinar, I know what's happening at the care home, which is really, really exciting for me to be able to do those things.
Absolutely. And again, you're going back to, what does the person actually need? You know, is it social interaction within a care home? Is it social interaction with family members? You know, and you can do that with
but
online.
It's using things like iPads, it's using things like all the devices that we all use at home, we use those in the care home, because there's no real reason why we can't use those there as well, so that you can build those connections. If they want to do Zoom, we were doing some befriending service, adopt a grandparent, and they're doing these amazing things where they'll be talking to someone in Germany because they're actually of German origin. I mean, things like that. It's amazing that we're able to use technology to help break down a lot of issues we've had in social care before.
Brilliant. Well, we'd love to see some results of that.
Absolutely.
Super. Thank you. Trudy.
So I spent 17 years of working in IT before running a care business, and when I was a student worked as a care worker. So it's kind of care has topped and tailed my IT career. And one of the things that that is aligned with my values in both my career in care and my career in IT is what in IT we call user-centered. Because great IT and the best IT professionals I've ever worked with are user-centered, and great care and the best care professionals I've ever worked with are person-centered. Two slightly different phrases that mean exactly the same thing. So for me, technology is really important. I'm a technologist. I love it. I see the advantages, but it's always about the people first. And that was why I delivered great tech that, by the way, was always on time and on budget. I know IT projects have a reputation for not being on time and on budget. And now I'm delighted that I can do that in a sector which is much more deserving than some of the other sectors that I served when I was working in IT. But it always comes down to people. I love that your question talked about improving outcomes, because that's the outcomes for people and society are really important. But I would question the use of the word efficiency, because I think that can sometimes drive the wrong behaviors, and it's a great side effect to have. But maybe if we aim to look at effectiveness,
Yeah.
And then efficiencies fall out of that, because I think there are a huge number of opportunities where technology can be used to support care workers and unpaid carers to spend more time caring and less time on other stuff. So Parvi mentioned about paperwork. So that's the obvious place to start. And although the care sector was way behind the curve, it's been a steep curve, and it's been really interesting to see in the last 10 years how much digitization has happened in care. What I would love to see is for us to leapfrog other organizations and have some of the best technology. And that is possible. If you look at, say, examples in other countries where maybe, you know, the internet arrived late, but then actually they bypassed that stage and went straight to mobile phone technology and are doing, you know, kind of microfinance on phones in you know, way out in countries that resemble different setups to ours. So there's an opportunity for social care just to look at what's the best out there, and cost-effective ways of introducing things. But the key is to look at, well, what are the problems you're trying to solve? So there's problems that care workers face day to day. And I think we need to be better at kind of understanding that and supporting them to do their jobs better. And that means listening to them, lots of co-design work. So putting outcomes at the heart of what we're doing to make the outcomes better for the people we support, and using our care workers in care homes and in domiciliary care to help us work out what those outcomes are. So things like rolling out ASCOT, the Adult Social Care Outcomes Toolkit. So we've embedded that in our technology in the last year, and we are looking if there's anyone else out there listening to this who wants to get involved with that, because we're looking at how do we collate more data and really show how what difference good care makes to people. Rotas, which probably more so in home care than in care homes, but they are the most complex beast ever. The logistics are challenging, and that's the perfect situation where technology can help to automate, to predict, and use AI. But there are specific things as well. So values-based recruitment, I think, is really key. And someone mentioned earlier about, you know, the workforce and how important it is that we change the mindset around what it is to work in care. And we want to attract new people into care that haven't got lots of care experience on their CVs but are the right fit. So if we're not worried about what's on their CV, how do we tell if they're the right fit? So we've developed with a psychologists, so using frameworks that have been well established in psychology to look at people's personality, values and interests. And we've been using that for 3 years now. It's a really easy tool where you answer a few key questions to get an assessment of what sort of personality you are. And we can look at the fit, and we're just starting to work with some other organizations. And again, I'm putting a call out for data, because the more data we have. So if anyone's keen to partner with us on that, we can look at, well, what makes a great care worker in this sort of organization. The benefit for us is our retention has improved massively since using this over the last 3 years. Yeah, and then looking forwards, there's a lot on AI. So we've got we call it Digital Dan, because we've got a support guy called Dan who gets all the questions. And so what we're testing now is it's not live yet, but we're feeding our AI tool the same questions that Dan gets, and then I compare the tools AI generated answers to what Dan actually gives them as an answer to look for accuracy.
Wow.
So watch this space, and we'll tell you more.
Look forward to hearing more about that. Thank you, Trudy. Eddie.
Yeah, so I mean, all of those things, Parvi's absolutely right. Digital has been a game changer in terms of rotoring, care planning, all that kind of stuff. Record keeping has just been fantastic. The worry is, of course, that every time we find efficiencies within the system, that's an excuse to give the sector less, because actually you're doing it and it's cheaper, therefore you don't need as much money. Well, you know, we've done that so we can spend more time with the people that we support. So it's a real shame. I'm sure there's more we can do. I was just thinking meds errors, things like that. I'm sure we can do something to make that a little bit easier. It's very complex, often in a very rushed environment, making sure that you give people the right medication, etc. Things like having a shopping list ready, so for a home care provider, so they know exactly what they need to get for that person, because the person's been able to check their food as they've been using it during the week out the fridge, and all this stuff exists already. We all have stuff even on our desktops, which is extraordinarily helpful in terms of helping us make tasks for our day. But I wonder whether actually we're looking in the wrong direction again. Maybe AI, we should be looking back at those who commission us and saying, actually, why do we have hundreds of thousands, not hundreds of thousands, but tens of thousands of commissioners and quality checkers, etc., in CQC and local authorities? Well, actually, you could probably do that through AI. Of course, the thing is that it's care providers, it's the market that's been innovative and has done the investment, and it's not been our local authorities. So they've not taken the time to think about the future, whereas we have, and that means they're slow to catch up.
And they're the ones who are going to benefit from it. But I certainly know social care is massively innovative and is able to adapt super quick, and unfortunately that's not the case, is it, within local authorities and NHS. Jazz, did you want to say final thoughts on that?
Yep, I will be quick. So I agree with what everyone else is saying. I think two main points I want to make. Number one is about data privacy, and the second one is about making sure that we don't transfer analog problems into the digital world. So if I do the second one first, because that's actually shorter to talk about, we already know that there's a lot of analog problems that exist. There's inequality in various different ways, whether it's racism, sexism, homophobia, whatever it is. There's a lot of different types of inequality and injustice, and whatever digital technologies we're creating, we need to make sure we don't just transfer that over into the digital world. And an example that I would give is when people are talking about using AI, specifically large language learning models, to collate a lot of data and predict certain things. A lot of the data sets that they have been trained on are the data sets that exist, and the data sets that currently exist are the ones that have been treated like, so it's basically men, and mostly white men as well. So there's very little intersectionality in terms of whether it's disability, whether it's in terms of race, whether it's in terms of gender, etc. And if you are training your LLMs on just male data sets and then expecting that to be applicable to everyone, you are just setting yourself up for failure, because people are different. The second point I was going to make about data privacy, and especially in the context of what's happening in the world right now, like there's a digital coup happening in the US and the US government right now. The NHS and all of the data that's associated with it is considered one of the prized assets. So the NHS is considered a prized asset of the UK. The NHS's data in particular is considered a prized asset, and there are so many companies who try to access it and who want it because it's like an absolute treasure trove of information. Social care also has huge amounts of data. It might not be under the same umbrella that the NHS has, but it has huge amounts of data. And so when we're talking about what we're going to do in the future and what the structure of social care will look like, I think one of the key things that we really need to be on top of is data privacy and making sure that individuals' data, it can be used to help them and to improve their outcomes, but it's not then used against them. There's a lot more I can say about that, but I'm very conscious of time, so I'm going to stop there.
And that what we've just been discussing there is a really good and important point. And I know, it was before I actually joined working for the IHSCM, I was still part of the social care innovators, and I was given a demo of the healthcare record in Denmark. And somebody actually showed their healthcare record and how that actually worked. And I don't know, but it looks super secure in terms of only the it was owned by the mother and father of the family, and only they could access and then give access to whoever. But it really needs some careful consideration, doesn't it? Because as you say, there is so much data that we have there. Eddie, did you want to just come in there? I know.
Just a final point, because you mentioned Denmark, so I thought it's probably worth mentioning, because we didn't cover it. The different structures that we have, because that's what this was all about, around the world, have not solved the problems of social care. No. So, whether you look at Sweden, which is mainly delivered by public employees, whether you look at Italy, where it's delivered by cooperatives, or you look at the American market, where it's kind of delivered by, well, no one, but everyone. No one has solved social care, and I think that's mainly due to two reasons. One is we don't value it. Secondly, there isn't enough money in it. And thirdly, importantly, and I think Jazz has touched on it directly and obliquely in many ways, it's mainly delivered by women and therefore is not valued. So I think, you know, all of those things we need to take forward and think about how do we change that.
And that is an amazing point to end this session on. Thank you so much for that. Thank you to all of our panelists. Thank you very much for everybody who has been involved. We have recorded this session. We are going to be sending this out. We are going to give all our members the opportunity to feedback, and we will gather as much information as possible. And obviously our next session, and I can't remember the date, but I'm sure it's in the chat, our next session will be about the cost. So we very much look forward to seeing you all then. So it is bang on 2:30. Thank you so much again, and I look forward to seeing you all next time. Thank you.